The process of muscle contraction is complicated. It's a process where action potentials travel down the motor neuron and release acetylcholine. The acetylcholine then binds to receptors, which then allow sodium to flow through and depolarize the muscle membrane. This depolarization then further goes down and releases calcium, and then causes the actin and myosin fibers to interact. A key structure in this whole process is the neuromuscular junction, the point where the motor neuron meets the muscle. And today we're going to learn about some diseases that happens when things go wrong. Let's take a closer look at the neuromuscular junction. Some of the key features of the neuromuscular junction include as follows. You've got a voltage-gated calcium channel that's located in the presynaptic motor neuron. On the postsynaptic membranes, you have acetylcholine receptors. We also have synaptic vesicles which contain acetylcholine. When triggered by the influx of calcium, these acetylcholines get released from the presynaptic terminal. You've also got a synaptic basal lamina that forms an extracellular matrix that connects the pre and the postsynaptic terminals together, and attached to them are acetylcholinesterases that degrade acetylcholine. The two diseases we're going to talk about today are myasthenia gravis and Lambert-Eaton myasthenic syndrome. Both of these are autoimmune-mediated diseases, which means that the body produces antibodies that target itself. The difference between these two is that in myasthenia gravis, the antibodies target the postsynaptic acetylcholine receptors, whereas in Lambert-Eaton syndrome, the antibodies target the presynaptic calcium channels. Both diseases cause proximal muscle weakness. However, myasthenia gravis has a characteristic of a drooping of the eyelids, ptosis, as well as a diplopia or causing double vision. An important characteristic, the muscle weakness in myasthenia gravis gets worse with muscle use, whereas Lambert-Eaton syndrome, the muscle weakness gets better with muscle use. Myasthenia gravis is known to be associated with thymomic diseases, whereas in Lambert-Eaton syndrome, the disease is associated with paraneoplastic syndromes, such as from small cell lung cancers. If we tested the anti-acetylcholine receptor antibodies, patients with myasthenia gravis would most often test positive, whereas in Lambert-Eaton syndrome would test negative. The reason why I use the words most often is because that sometimes myasthenia gravis can be caused by a different type of antibody, such as the muscle-specific tyrosine kinase antibodies. Post-exercise nerve conduction studies in Lambert-Eaton syndrome can sometimes show a doubling of the muscle action potential amplitude. This is consistent with the characteristic that Lambert-Eaton syndrome gets better with muscle use. The treatment of myasthenia gravis includes the use of acetylcholinesterase inhibitors, such as pyridostigmine. The rationale behind this is that by inhibiting the breakdown of acetylcholine, we can have a greater chance of the acetylcholine binding to the acetylcholine receptors and causing a muscle contraction. However, these treatments will not work in Lambert-Eaton syndrome, as the problem in Lambert-Eaton syndrome has more to do with the releasing of acetylcholine from the nerve rather than the binding of acetylcholine to its receptor. In summary today, we talked about how a motor neuron signals a muscle to contract. We talked about a few key structures of the neuromuscular junction. We've also compared and contrasted the differences between myasthenia gravis and Lambert-Eaton syndrome. But to test your understanding, can you think of the reason why in myasthenia gravis the muscle fatigue gets worse with use, whereas in Lambert-Eaton syndrome the muscle fatigue gets better with use?